Hi, my name is Giang. I'm a pharmacy student.
And my name is Laura Espinosa, and I'm an optometry student.
Today, we both present a patient case on Mr. Modesto Espinosa. His chip complaint that his hand and feet get swollen recently. Modesto Espinosa is 51 years old man with chronic kidney disease. He presented to the urgent care clinic with complaint of the peripheral edema that started last week. He had kidney transplant 1 year ago and was feeling normal until he developed edema in his hands and feet. That wasn't with his long standing and walking because his job as the manager for the AT&T shop, so he required to walk a lot, so this become difficulty for him to walk around. Also, a urinary test was performed last month in the outpatient setting, revealed the ratio of urinary protein over urinary creatinine is 0.6 with classified proteinuria. Patient have kidney transplant with proteinuria have very high risk for cardiovascular disease, which can lead to graft loss and death. So we would like to prevent this from happening. His past medical history includes kidney transplant 1 year ago. He had chronic kidney disease, diabetes type 2, hypertension, hyperlipidemia, high blood pressure. His family history: his father had diabetes type 2, mom has cardiovascular disease. For social history, he is a manager of the AT&T shop. He lived with wife and son. River drinker, but he quit on 2013. He on multiple medication that include Dapsone 100 mg tablet by mouth once daily, atorvastatin 10 mg tablet by mouth once daily, metoprolol titrate 50 mg tablet by mouth twice daily, nifedipine long-acting 30 mg tablet by mouth once daily, glipizide 2.5 mg tablet by mouth once daily, allopurinol 100 mg tablet by mouth once daily. Here on tacrolimus 1 mg capsule by mouth once daily, sitagliptin, which is Giang-video, 100 mg by mouth once daily, mycophenolate 180 mg tablet by mouth once daily. He had no non-allergy. For the review of system is not available. For his physical exam, everything looked very good except his edema examination recorded 1+, so very mild edema. And for his lab, everything within normal limit except albumin very low, like 3 grams per deciliter. That indicates that the protein leak out of the blood vessel. It can hold on the fluid. That's why he have edema. And his serum creatinine is 1.4. BUN 30 is very high too. And glucose is 98 mg per deciliter. And A1C 6.2 is very good. And albumin over urinary creatinine is 0.6, creatinine clearance 62, and for his problem list, I have adverse drug effect. Glipizide can cause weight gain due to its induced insulin release. Nifedipine can cause edema, and for drug-drug interaction, glipizide can increase the accretion of allopurinol, and for CYP3A4 interaction, Giang-video, atorvastatin and nifedipine, they are CYP3A4 substrate, and medication selection for him is not optimal for the metoprolol titrate because it's taking a twice daily dosing, and since he on multiple medication, we would like to minimize too many dosing if possible. So metoprolol titrate is not good dosing for him, so we need to change to something else. For the subnote of chronic kidney disease, subjective, he reported mild edema of hands and feet, which interfered with his job. He was previously a drinker but quit in 2013. He currently taking nifedipine long-acting 30 mg tablet by mouth once daily, which can cause the edema.
And the patient does not report any blurriness or any transient loss of vision.
For objective, he report no non-drug allergy. He have diabetes type 2, which is very controlled right now because his A1C 6.2%. Hypertension, which is very controlled. His blood pressure is 121/76, and his lipid profile very controlled too. The total cholesterol 190, LDL 40, HDL 35, triglyceride 96, which is very important for him to keep this range because it will protect his from cardiovascular disease too. And for his weight 203 pounds and his height 5 feet and 9 inches. So his BMI 30. He classified obesity class 1. For chronic kidney disease, he had kidney transplant 1 year ago. He diagnosed with proteinuria because his urine albumin over urine creatinine ratio is 0.6, which is pretty high. He hit BUN is 1.4, it's okay. And his creatinine clearance 62, it is little bit low. And serum albumin is 3. His vital sign, blood pressure 121/76, heart rate 75, and respiratory 20. For the guideline recommendation of immunization for a patient with diabetes type 2, he should have immunization for influenza, pneumococcal, hepatitis B, and he have everything updated because he take it on. He have immunization beginning of this year, January 2014.
Yep. And an optometrist would like to most likely see their A1C levels and their blood pressure levels. And for an eye exam, we would like to see their visual acuity, their pupils, how they react to light and no light. We want to see how their extraocular muscles work together. We want to see their interocular pressure, and most importantly, we want to perform a dilated fundus exam to see the back of the eye.
For a pharmacy assessment, any 51 years old male with chronic kidney disease, he have multiple diseases as well as recent kidney transplant, and they were prescribed nifedipine long-acting 30 mg tablet by mouth once daily, which used to control his post-transplantation hyperuricemia. However, after 1 year taking nifedipine, and we had recently noticed edema happening to his hands and feet. Furthermore, nifedipine can also cause proteinuria according to the guideline. If patient have increased albumin accretion, angiotensin II inhibitor or angiotensin II receptor blocker is the drug of choice to prevent progression of proteinuria. Therefore, nifedipine can switch to apps such as losartan. And my plan for pharmacy goal therapy that to prevent drug interaction, drug adverse event of current medication, provide appropriate therapy to relieve his edema and further prevent progression of proteinuria to protect his kidney. We want to prolong his survival of his kidney, long of his life, and minimize adverse drug effect. And for pharmacologic therapy, I recommend to discontinue nifedipine and switch to losartan 25 mg by mouth once daily, and discontinue glipizide and replace with metformin extended release 1000 mg by mouth once daily because his serum creatinine very controlled. So metformin is a drug of choice for him at this moment. And also discontinue atorvastatin and replace with bravastatin 40 mg by mouth once daily because due to drug interaction. We should discontinue metoprolol titrate and replace with metoprolol succinate stacked from 12.5 mg once daily. For non-pharmacologic therapy, I would recommend to monitor weight and his BMI, initiate his diet changes, and reduce fat and high protein intake to protect his kidney, and continue current physical activity schedule that he works on.
And for an optometrist, we want the patient to come in yearly for a fundus eye exam. So we want to dilate them to make sure that we see everything in the back of the eye, make sure there's no vascular changes. And if they do report any loss of vision or blurriness, they should come in sooner than a year.
Okay, for pharmacy monitoring parameters, I recommend to monitor blood pressure, lipid profile such as total cholesterol, triglyceride, low LDL, HDL, especially his serum creatinine clearance when he will be put on metformin, because metformin is contraindicated in male patient with serum creatinine more than 1.5. So serum creatinine very important parameter to monitor for him. And his hyperkalemia, BUN, acute kidney injury when he will be put on losartan, and his edema, A1C should be within normal range. For patient follow-up, he should check back at the clinic to determine if there are any changes based on monitoring parameter weekly. He should report immediately any symptom that worsen. Adverse drug event, toxicity can occur as a result of changing therapies.
And then for the patient, as I mentioned, we want them to come in yearly for a fully dilated exam. And we want to just make sure that we prevent any retinopathy, as in hypertensive retinopathy or diabetic retinopathy.
For patient information, I would like to let him know that losartan will not curb his chronic kidney disease, but rather than it's used for long-term control his proteinuria, so to protect his transplanted kidney and to prolong his life too. He should return for follow-up with the pharmacist in 3 months.
Okay, and for our patient, there are a few things that I would educate them, but we're going to focus mainly on hypertensive retinopathy. So because he does have systemic hypertension, he is at risk for atherosclerosis, which can then cause further complications of coronary heart disease, strokes, and renal disease. Also, there are going to be some ocular complications as well, including arteriolar sclerosis, branched retinal vein occlusions, arterial narrowing, and mainly vascular leakages. So we want to make sure that the patient is controlling their hypertension and their diabetes to prevent from having any type of retinopathy affecting their eye. And there are some signs that an optometrist does look for. Some of them include early thickening of the arterial wall, so we will notice a different change of color anytime we reflect any light in a dilated fundus exam. Also, we want to check for any cross changes. We want to make sure that no arteries, because they are being affected by the hypertension, we don't want them to affect the veins or basically compress them like a water hose. When you close it up, a lot of blood is not going to go through. It's going to back up some blood, cause some leakage. And also the main thing, we don't want any vascular issues such as the flame-shaped hemorrhages. We don't want any cotton wool spots. And we also don't want the swollen optic nerve head. So this is a picture of an eye that has a swollen optic nerve head. So you'll see that it's not distinctive. You don't see the round disc. And then the macula over here, it should be a red spot. However, you see different spokes coming out of it, and that is indicative of hypertension. So we just want to make sure that the patient doesn't get to this level. So if they do have some type of signs of hypertensive retinopathy, we will not have them come not only for a year fully dilated exam, we're going to have them come in instead every 2 to 3 months to follow up to make sure that it is controlled and it doesn't further. And then after that, we see that it is controlled, we're going to check them every 4 to 6 months.
Thank you very much for your listening. Thank you.